would like to know whether the leakage was continuous or intermittent, whether the leakage was associated with any change of position, and was there any antecedent history of trauma or any obstetric history or any surgical history after which.
So who is discussing?
Sir, this is Dr. Patnaik from Vedanaikam Hospital. Hello.
Sir? The next slide, sir. Hello?
Hello.
Yes, sir. Can you change to next slide, sir? It is there everything.
Yeah.
The patient was all right 6 months ago when she had undergone elective open total abdominal hysterectomy with right salpingo-oophorectomy for a large fibroid interest. Post-operative, patient was informed about insertion of a ureteric stent for some intra-op complication and was discharged with stent and Foley's ensued. Patient was followed up for 15 days and Foley's was removed. Post-Foley's removal, patient had pervaginal leakage of urine for which she was reviewed and stent was repositioned. Patient was followed up for 2 months during which 2 times stent changed. No pervaginal leakage during this period of time. Post-stent removal, patient has pervaginal leakage along with intermittent normal voiding.
So from this slide, it is evident that there was a gynecological surgery post which this has occurred. I wanted to know like which particular site they had stented, and did the surgeon mention about the intraoperative difficulty he faced, like adhesions, bleeding, or any difficulty which he faced during the surgery? And what was the reason for stenting? Where was the injury?
The stenting was done on right side, sir.
Okay.
And the fibroid uterus was a very large fibroid.
Okay. I wanted to know, like, at the time of surgery, what injury he had encountered? Like, was it a partial injury, just a contusion, transaction, complete transaction? Like, what was the
How will those details help you at this point?
Now, sir, it's already evident, sir. It won't help much, sir.
Yeah, so you are not blindly asking questions just because you want to sound smart. You have to ask questions with a particular aim in mind.
Yes, sir.
So is this history enough for you to make a diagnosis? Yes or no? Whatever is written on the slide.
Yes, sir.
Yeah, so why don't you commit to that?
Yes, sir.
What is your diagnosis?
Most probably this is a uretrovesical fistula. Uretrovaginal fistula.
Okay, agreed. And how would you explain this sequence of events that there was no leak and then when the stent was removed, suddenly there is a leak?
Sir, as long as the stent was there, the urine was through the stent and around the stent, it was being drained into the bladder. But once a stent was removed, then it started to leak.
Okay, let me put the question differently. Suppose this patient came to you tomorrow in your OPD and said, I'm very happy, my leak has stopped. Would you be worried or would you be very, very concerned? I mean, would you be happy or would you be concerned?
Sir, with the stent in situ, sir, the leakage has stopped.
No, the stent has been removed. Today she's come saying leak with this history. Tomorrow she comes to you saying my leak has stopped. I'm very happy. Would you be happy or would you be very concerned?
Sir, I would be concerned, sir. Like either there may be healing of the fistula or there may be some collection going on around that area, which may give rise to complications later.
I will ask this question to Imran. Is he there? Okay, Saurabh?
Yes, sir. Uh, Sir, if the leak has stopped, sir, the fistula must have closed, or
Is there anybody who has a different viewpoint?
there is any. We look for the upper tract changes, the hydronephrosis or stricture causing the obstruction, and so there is no further urine leak from the site of injury, sir.
So, exactly. Now, you need to understand the pathophysiology of ureteric stricture following gynecological surgery. There is always some amount of ischemia of the ureter at the level of injury. It forms a stricture and the leak is proximal to that level. If the leak stops, it means your kidney has stopped and functioning and is going to pack up very soon. If a collection forms later, they will present with other symptoms. And if it is leaking out of the ureter, it will find its way out through the vagina. Only the vagina will not heal.
Yes, sir.
So if it stops leaking, this is a commonly asked question. If you're suspecting a ureterovaginal fistula and it stops leaking, unlike a vesicovaginal fistula, you're not happy.
Yes, sir.
Okay. Okay, so he correctly asked which side. I'm assuming that since it was a right salpingoophorectomy, it would be the right side. But yes, the question is correct. Which side was stented? Do we have that answer?
I think he mentioned right side. So
Oh,
on
okay.
Pratik, Patnaik, how will you on history say that it is ureterovaginal versus vesicovaginal?
Sir, there are some relevant points in the history which we have to inquire. Sir, whether the leak is intermittent or continuous, and also is there any relation with the position, change of position, and also the intraoperative details which will give us the idea,
Intraoperative details,
sir, of the injury, the surgery which led to injury, sir.
no. The other important history is whether the patient is voiding in between
Yes,
the leak.
yes, sir.
It can happen with all types of fistula, but it is more likely with the uretrovesical. Patient is voiding normally, good volumes,
Yes, sir.
and there is a leak also. So that is more in favor of vesicovaginal. Versus if it's a ureteral, uretero, the first one what I said was ureteral.
Yes, sir.
So if this patient comes to you 2 months now, no, already 6 months, I think, since the initial surgery. So what is your timeline? Let's say she comes to you 2 weeks after the catheter is removed.
Sir, audio is not clear, sir.
Audio is not clear. 1 second. Then another.
Anything better now or same?
Worse.
Worse. Now?
I can hear.
Huh? Okay. Now I changed the microphone, that's what. So the basic thing is the timeline. So if a patient has come 2 weeks after the catheter removal, after the surgery,
Yes, sir.
what you will do?
Sir, I will wait for at least 2 to 3 months for the fibrotic process and all the inflammatory process to settle down.
So if it's, let's say, in this case, it is a ureteral leak.
Yes,
So
sir.
we'll be waiting. As Dr. Manish said, you're concerned about the obstruction leading to poor function.
Yes, sir.
So the kidney may pack off also.
Yes, sir.
So what you will do?
Sir, for adequate duration of time, sir, stenting would be needed, sir. or many people opine that immediate surgery also does not lead to worse outcomes.
What is that immediate surgery means?
Like intraoperatively, if it has been discovered.
Yeah, intraop, there's no doubt about it. Intraop, nobody has any, there's no debate about intraoperative. Now you say early means the patient has, you repaired it, intraop, and the patient has come back after 2 weeks with the leak.
Yes, sir.
In that case, what do you do? Silence.
So few studies have shown that early repair also does not have a worse outcome, sir. It has more or less equal outcomes.
See, you don't go by individual case reports and, I have done this and that's what sometimes they present in the conference. You go by what is written in the books.
Yes, sir.
What is the general principles?
Yes, sir.
Don't say, oh, let's say we have managed one patient like that. So that should not be the standard of care.
Yes, sir.
So what you are going to tell the patient and what you are going to do? Because if I am a patient who is leaking, I would definitely want, the leak should subside and I can get back to my work as usual, as routine.
Sir, if it is a low-lying fistula and in the absence of infection, we can try vaginal approach also immediately, sir.
Sir, at 2 weeks, I would like to put on retrograde stenting, sir. If it is successful, I would wait for 3 months and later reassess with repeat CT IVU and take a call, sir. If stenting is not successful, I would put a nephrostogram and repeat the assessment after 3 months, sir.
So I think, Prabhu, what he wanted was that you should wait. You have friable inflammatory tissue. You do not want to go in while the infection is still there. Probably more important for a vesicovaginal fistula, but even in a ureterovaginal fistula, ideally you should wait.
Yes, sir.
If possible, put a stent, but warn them that whenever the stent comes out, it will leak. So the process is that a stricture has formed, proximally it has started leaking. Unlikely that you'll be able to stent. So I think the safest solution is to put them on pads. Correct, Prabhu?
Yeah. Now, let's say the patient has come with the leak and you have asked for ultrasound. So will it give me any information or it's of no use?
Ultrasound will give information about the upper tracts. So if there is any hydronephrosis because of stricture.
So if there is hydronephrosis or stricture, what will you do immediately?
So we have to do nephrostomy.
Will you attempt a stenting or you directly go for PCN?
So we can attempt for stenting first, sir. And if it does not go, then we can go for a PCN.
Why will you put a PCN?
So to relieve the obstruction and also the chances of infection will come down, sir.
If a patient comes with pyelonephritis with infection, yes, you will put in a PCN.
Yes, sir.
But if the patient just has urine leak, there is no indication for putting in a PCN.
Yes, sir.
Okay?
Yes, sir.
It is much safer to just let her leak and come back later and have a surgery.
Yes, sir.
I can. Oh, we can continue with the next slide.
So no issue of leakage of urine with change in position, sir. No issue of urine leak during cough and exercise. No issue of purulent discharge. No any storage or obstructive LUTs. No issue of burning maturation. No issue of fever. No issue of dysuria. And no issue of hematuria, sir. No issue of diabetic.
Who is presenting?
Sir, Vignesh.
I didn't get that name.
Sir, Vignesh.
Vignesh.
First year, sir.
Go back to the previous slide.
Yes, sir.
Yeah, you're very lucky that Dr. Mohan is not there. What is the difference between burning micturition and dysuria? Yes, Vignesh.
Yes, sir. Sir, in dysuria, pain may be associated.
Okay, we won't waste time here. Dysuria is a term that should not be used at all.
Okay,
It
sir.
used to be used for burning micturition. There is no difference. There is a whole society that is only doing nomenclature in these terms. You have to go and read those terms, what they mean.
It is given up. It should
Yeah.
not be used.
Dysuria cannot be used. Burning micturition is what you call. Secondly, now what do you mean by obstructive LUTs? What is the correct term for that?
Voiding, sir.
Yeah, so it is called storage symptoms and voiding symptoms.
Okay.
Obstructive LUTs implies a diagnosis, which is why it is not used at all. Okay?
Yes, sir. No issue of
Go
diet.
back, go back. When we have especially a psychovaginal fistula, when this patient comes back to you after repair, in addition to all these questions, you will again ask her something else. What is that? What is the complication of VVF repair, which, let's say, multiple VVF repairs, which a patient comes back to you? There is no urine leak, but something else has happened. This question is to Dr. Patnaik. Patnaik, what's your first name, man?
Sir, Soumya Patnaik.
Soumya. Okay, so we prefer to call you Soumya. Yes, what is your idea? What do you think can happen after repeated VVF repair? It's a complication which we very often don't talk about. Anybody?
Endometriosis can happen.
Huh?
Uterus is out now.
Where did that come from? Okay, it's dyspareunia.
Yes, sir.
Okay.
No, I thought the bladder has become small and
Sir, I would like to know the details of the examination, vaginal examination.
Personal sleep, married, sleep pattern normal, bowel and bladder habits normal, denies tobacco chewing and smoking. Patient renal examination, conscious, well-oriented. For vaginal examination, vaginal mucosa normal, evidence of pooling of urine in vagina. No growth, no cystocele or no rectocele, no genital skin extoration.
I would like to know, was there a leakage of the urine detected from which part of the vagina? Was there any induration anywhere?
No, how will you know that in local examination? For that, you have to do it under anesthesia. It's very difficult to see where is the leakage from. What is double dye test? What he has written?
Sir, double dye test, we place a tampon in the vagina and prior to the onset of the test, we asked the patient to take phenazopyridine orally, and then we instill methylene blue per urethra. And then we wait for, after removal of the catheter, we will wait for 2 hours and we will observe whether the staining is orange in color or blue in color. And that would determine whether it's a ureterovaginal fistula or a vesicovaginal fistula.
So if this both colors are there,
So it's a ureterovaginal fistula, sir.
okay. So what is 3-swab test? How is it different from this test, double dye test? Hello?
Yes, sir.
Both are same or different?
Sir, in double tie test, we just place one tampon and we use 2 dyes. And in 3 swab test, we utilize 3 swabs which are placed in the vagina, sir, introitus.
Why? That's Vinod's question. How do you do it? What is your interpretation?
So to diagnose this uretrovesical or a vesicovaginal fistula, a uretrovaginal or a vesicovaginal fistula.
So how do you do that 3-swab test?
Why you need the third swab? Why 3? Why not 2? Or why not 4?
Okay, please go back and read about this.
Yes, sir.
Now, what is missing in the vaginal examination? What does per vaginal mean?
Examination using fingers, sir.
So now what is missing in the, not you, Praveen, we'll stick to rules which Dr. Mohan has made.
Okay, sir.
So what is missing? Now what is missing?
So whether the speculum examination was done or not, sir.
Yeah, so you are expected to ask that, man.
Yes, sir.
Not after I'm asking you what is missing. Please
Yes.
be on top of things. You would normally put in a speculum. Would you expect the vaginal mucosa to be all normal with a ureterovaginal fistula, or would you expect some sort of a induration to be palpable?
Yes, sir. So some sort of induration should be there. Induration redness will be there, sir. And we will be able to appreciate the leakage of urine from one particular point. If it's a uretrovesical fistula, sir, definitely there may be associated with some sort of spurting, like intermittent leakage or spurting of the urine.
Yeah, you would expect some induration. You would expect some induration. You would expect to see some leaks.
Yes, sir.
This jet of urine, I don't know, man. Whether
It's
too much of,
There is no jet, and usually there is no inflammation also.
Yes, sir.
Any other information you want to know? Plan the management.
Location of the fistula.
Location, exactly. The length from the.
Yes, sir.
So do you want to know the capacity and the compliance of the vagina? Is it important?
Yes, sir.
Why is it important?
Sir, so we can counsel the patient for post-procedure difficulties which he may encounter, sir, dyspareunia
And why is this vaginal mucosa, everything normal? Is it important? Mucosa, vaginal mucosa, presence or absence of senile vaginitis?
yes, sir.
Age?
Yes, sir. So usually in older females, it would be atrophic.
Okay, anyway, this patient is 39-year-old, but that is also important
Yes, sir.
because success rate of VVF also depends upon the vaginal mucosal health capacity.
Yes, sir.
So what will you do next? Local examination done.
So the clinical examination confirms the presence of ureterovaginal fistula.
Are you sure? Are you sure? So
How are you sure?
Can I go with the clinical examination and plan my surgery?
No, sir. I would like to go for imaging, sir.
Because you said confirm. Yeah, you are confirming there is a leak.
Yes, sir.
But it's definite. Whatever your dye test and other tests, it's not definite. You cannot plan the actual procedure based on that.
Yes, sir.
So dye test and all now very rarely it is being done, because as I said, as Sir told, even if it is done, in order to confirm, you have to do imaging. You cannot just decide intervention only based on dye test.
Yes, sir.
So in the blood test, what do you want to check?
Sir, I would like to check the creatinine level, sir, the routine urine examination and the urine culture.
I think the patient is on a stent, so you will expect all this.
I would like to know the creatinine level, sir.
So our culture is positive. So if you want to give her antibiotics and make the culture sterile.
No, sir. She's already on a stent. She is expected to have a positive culture finding, sir.
Stent is removed, I think.
Stent is removed, no?
Yes, sir.
Vignesh? Yes, sir. Stent was removed after 2 months.
Yes, so you're supposed to tell us that when we are going the wrong path.
Okay.
So the stent is removed.
Yes, sir.
There is still some pyuria, there is a positive.
Still pyuria positive culture. So what do you want to do?
So will you go by the exact culture? Or see, routine cultures when we talk, it's when a patient is having a normal system. The patient is leaking, there may be a vaginal urine which comes out and it may be a contamination.
Yes, sir.
Keep that in mind instead of treating based on that meropenem and all that. So,
Yes, sir.
remember, what is this 362 lakhs or it is 3.62?
3
Anything more you want to know in the blood which before planning surgery? The reconstructive procedure.
Yes, sir. So the total protein albumin level, sir.
Because patient just underwent some major surgery. Okay.
Vignesh,
Yes, sir.
your slide qualities need to improve.
Okay, sir.
Lax has a completely different meaning when you spell it like this. All these mistakes, please don't come back with these next time.
Okay. Sorry.
Manish,
Yes, sir.
the lax makes a lot of difference both in platelet count and in cold cash. In cold cash.
Yes, sir. The number is wrong, the spelling is wrong. Anyway, go ahead. So you wanted to image. What image would you prefer?
I would prefer CT scan, sir. So CT IVU, I would like to prefer.
No, why are you asking that investigation? Like thinking, what are you thinking and asking those investigation? CT.
We can localize the site of leak, sir. The site of fistula, depending upon the extravasation.
Okay. You want to do CT or you are only IVF is sufficient? IVU.
So I would like to do CT abdomen, sir.
So the question is, how do you think a CT IVU will score over a standard IVU, conventional IVU?
Sir, the site of fistula, the size of fistula, the location, so all these things can be determined with the help of CT scan. The standard.
Your suspicion is a ureterovaginal fistula.
Yes, sir.
What additional information do you expect a CT IVU to provide? You need the level of the fistula, you need to decide based on the level of the fistula.
Where do you expect the fistula to be, and why will the CT give more information? Do you think it will be at somewhere else? In any gynec procedure, what are the levels of injury?
So it's mostly in the lower ureter, sir.
Okay, so if you're suspecting a uretero,
That is not the commonest thing.
Sir, the infundibulopelvic ligament.
That is a common system. That is the common system. People make a mistake and say that, well, it's probably at the level of the ureter, uterine artery. No. It's at the infundibulopelvic ligament that what causes damage to the uterus.
okay, we'll give you the imaging that we have.
See, when the question is asked as to what is the difference between IVU and a CT scan to make a diagnosis, think of everything that is possible in the IVU and think of everything that is possible in the CT scan. Prima facie, there is probably no difference. The only advantage that I see in a CT scan is that you are able to scroll down the images. At every point, you can scroll and see, okay, the ureter is up to that point, it's clear, it's at infundibular, it's clear, lower down, it is a problem. So I will have some idea as to where exactly the leak is, that's all. Whereas in an IVU, the problem is going to be, it will be a blush wherever it is. More importantly, it's the function of the kidney that is mandated. In many of these patients who do have obstruction and it is not recognized, then the kidney gets obstructed and the kidney loses function. So whichever way you do it, it's not going to help. The advantage of both CT and IVU, or the biggest thrust that they use, is the fact that the kidney is still functioning. And therefore it is able to execute the contrast. And hence, when you do the ultrasound first, it's important to look at what the size of that kidney is, because many times patients have a ureterovaginal fistula. Not all of them leak urine. Some of them may leak a small amount and they think it's they don't know where it's coming from. Some of them have an obstructed ureter and slowly the kidney vanishes. So there are various grades of ureterovaginal affliction. So if the kidney is obstructed, then the ultrasound will show gross hydronephrosis, tilt parenchyma, then you are doubting whether this is going to work at all, any of these experiments. So any contrast study, the basic fundamental principle is that that kidney should be able to excrete that contrast for us to make any sense out of the image. All right. So you see, they've done an IVU for this patient.
Sir, if I would say that a CT IVU would give me better information if I'm suspecting an additional BVF, would that be correct, sir?
True, yeah. All the other pathology, the one side, both sides. Even here, actually, there's a BVF. If you suspect it and you take the right images, you probably will see the BVF, provided the patient is complaining.
Yes.
And whatever you might say, I mean, I could argue this completely and say that ultimately I will do a cystoscopy on this patient. When I do a cystoscopy, I will do a retrograde. So why the hell am I doing all this test?
Yes, sir, that's a point I would like to emphasize, that even patients with small amounts of intermittent leak do not assume, with all these findings also, do not assume it's only a ureterovaginal fistula. There have been women who have been devastated because a small pinpoint VVF was not treated. They were being treated by psychiatrists instead of being correctly diagnosed.
Absolutely right.
So do a very careful cystoscopy under anesthesia for all these patients.
More importantly, you don't know how many, whatever imaging you do, it will not tell you how many fistula there are. It will just show you there's a leak. So that word careful cystoscopy is the one. Never assume that there's only one fistula. There could be more than one. So spend some time and don't do this under local anesthesia, okay? Most important, you should be comfortable. Not the patient. You should be, you're going to put knife to skin ultimately, no? Do it under anesthesia. He's trying to cut corners, one quick scopy, doesn't work. You'll burn your fingers.
Vignesh, it's a simple matter. Vignesh, it's a simple matter to cover Mrs. Shashikala's name. Please get into that habit. Patient identities have to be kept hidden when you're making public presentations.
Okay.
Okay.
Read the IVU.
Yeah.
Fine.
Can you read this IUP and interpret?
Soumya?
Yes, sir.
Read the x-rays.
So I can see the right pelvic calyceal system dilated, sir.
Start with plain X-ray.
Don't say I can read the IVU. Learn to read the X-ray. This is the IVU series of a so and so. You know, like how you're going to present it in the exam. It's like that training. Huh?
So this is a IVP series, sir. The first X-ray is a plain X-ray which shows the lower ribs, the vertebra and the pelvic bones along with the dilated bowel. After injection, 5 minutes after injection of the contrast, I can see the dilated.
Is there any abnormality in the KUB?
No, sir.
Then mention. I don't see any obvious abnormality in the KUB region. That's the advantage. Any stone, this, that, I don't know.
Sir.
You talked about a stent. If there is a stent, then mention it. Is there encrustation on the stent? Mention it. These are all points that are to be written, mentioned in a patient who's got a KUB. Okay.
Sir.
If there is an obvious bony deformity, kyphoscoliosis, then you mention it. Okay.
What are the soft tissue shadows you should comment on in an X-ray KUB? You have missed out.
So the renal silhouette, sir, and the psoas shadow, and the peripherally placed the bowel gas shadow, sir.
Yeah, so if you don't see the renal shadow, please say that. So don't just pass off an X-ray KUB
Yes.
like that. An X-ray KUB, I think if you get stuck in an exam on an X-ray KUB, it's problematic because it can go on and on.
Just to also add to it, that don't assume that in the KUB X-ray that only these things. You could also see the shadow of a bladder.
Sir.
You could see a soft tissue shadow in the pelvis. In a female, it may be uterus, it may be ovarian cyst. In a male, it could be the bladder. Do they advise patients to void before doing a KUB? Or do they just take a KUB?
The void before.
Yes. It is expected that the radiographer will tell the patient to pass urine and come back for the X-ray. So if you do see a bladder shadow, you can see it, especially in elderly men, you can see the bladder shadow, comment on it. And then remember to ask the patient, did the radiographer ask you to pass urine? That's what is supposed to be done. Sometimes they don't do it, so you have to double check.
There is a prompt uptake and excretion of the contrast from both the sides. The drainage of the contrast from the left side appears normal. On the right side, there is dilation of the pelvic calyceal system. The ureter is also dilated and it is kinked in the upper part. There is no obvious extravasation of the dye which I can see, sir.
Up to where is the dilatation in the ureter?
Sir, to the mid-ureter, sir. The
Mention-
parasacral region, right side.
No. When you talk about segments of the ureter, are
Mid-ureter.
you talking of endourological classification or are you talking of the anatomical classification? That's the important thing. In a patient who got a stone disease, you talk about endourological, which is upper ureter, lower ureter. This is anatomical. So you say, well, exactly the ureter is obstructed, you can see it.
Sir.
Can't you see it there?
Yes, sir.
Huh?
Speak in terms of the vertebral level. What do you see? I understand. What is the vertebra there?
It's so in the parasacral region, sir, I can see, sir. Adjacent to the sacrum.
So sacrum has 1, 2, 3, 4, 5.
Yes, sir. Residual property.
Whatever, you can say at least below the sacroiliac joint.
Yes,
Just
sir.
maybe S3.
Yes, sir.
You can see that ureter there, stopping at just
Yes, sir.
below the SI joint. You know, it's curving
Yes,
and
sir.
crossing and stopping there.
Sir.
All right? Yeah.
But
What else? What else should you comment on here?
Right.
You said you so don't see any extravasation.
Yes, sir.
Are you sure? Look carefully.
Sir, behind.
Compare the KUB with this 20-minute IV. Compare it also with, compare with the 20-minute IV.
So behind the bladder, we can see that this particular region, which may be.
So when you are reporting on an X-ray, even in the exam, if you see something that is abnormal,
Yes, sir.
you say that I see the possible extravasation of contrast in the 20-minute film. However, this seems to be obliterated as the bladder fills up. As the bladder is filling up, that seems to go. All right. I also see it in the 5-minute film. There is something
Yes,
there.
yes.
But it is not there in the KUB. So look at the KUB and see whether that whitish thing is there.
Sir.
Because you said there is no extravasation, I pointed this out to you.
Sir.
What is more important? Look at the after evacuation film.
Yes, sir.
There is nothing there. So what happened to that contrast, that white thing there?
That has also leaked out.
Possible leaked out. Must have leaked out. Bladder is empty. What is more important in this after evacuation film that you can make out? And with some degree of confidence rule out. Dr. Manish mentioned about something.
There's no obstruction.
Is there a VVF?
No, sir.
Sometimes in the after evacuation film, you may be able to see contrast in the vagina. Right? Especially if they've taken a lateral film, or even sometimes right at the center you will see. All right? Now, many of these IVUs are not done, most IVUs are not done in standing position, they're in supine position. So some contrast will stay in the vagina. So you're able to see that in the after evacuation film, you see the contrast, patient passing. Patient goes to the toilet, passes urine, comes back and lies down. In the act of passing urine, some will leak into the vagina, some will come out. And still there will be some staining, so you'll be able to see something. If you are suspecting a VVF, also additionally, never assume there's only one lesion. In addition, if you are suspecting a VVF, then the radiographer or you should tell them, please take some lateral films in the bladder so that you can see what's happening. Okay. The reason why I'm pointing this out is these are simple cases where you can go completely south. You can finish yourself off by missing out something. You do a ureteric reimplantation, the patient is leaking because you missed a small hole. When there is injury, surgical injury, you don't know where all it can get. In the hurry-burry of everything, anything can happen. So just never get carried away by many of these things as far as incontinence in women is very, very dirty problems. You can miss the boat and you can be in serious trouble.
Complete the IVU, always complete the opposite kidney and the bladder. Sometimes the bladder is commonly missed. Here you are interested in knowing the capacity of the bladder.
Yes, sir.
Why you want to know that?
So the bladder looks of sir, adequate capacity, and in the post-void film there is no residue, there is no filling defect, there is no.
He asked you a very specific question. What is there in that bladder film that makes you happy or unhappy?
So the presence of any filling defect, irregularity, presence of any diverticular.
Okay. Anything else more important? I'm sure he asked that question with reference to what do you want to do for this patient?
Suppose the bladder was this big.
Yes, sir.
Would you be worried? This is the size of the bladder.
Yes, sir. Because so the capacity of the bladder is important if you are contemplating a Bowery flap.
Okay.
After Bowery flap, the capacity of bladder is supposed to get reduced.
Anything else? Well, you are not contemplating a Bowery flap. If the bladder is small, then even a ureteric reimplantation will be difficult. Isn't it? Direct ureteric reimplantation.
Yes.
You won't be able to move it around.
Yes.
Huh? So it's important to look at the bladder and see its distensibility. That's what he talked about, bladder compliance, everything is filling up nicely. Can I get it from point A to point B? So, supposing the bladder was small. Supposing the bladder was small. And this is a lesion. Then what are you going to do? The X-ray is as it is, but the bladder is tiny now. It's small. She's got terrible. She also got additional frequency. She's got a problem with the bladder.
So you can go for transuretral-ureterostomy.
Yes, very good. That is a very good operation in a situation like this. Okay? You know what are the contraindications to that operation?
Presence of
That's an obvious next question.
Yes, sir.
In the exam, you ask one question, you must know what is the obvious next question. The next question is this: what are the contraindications for TUU?
So, history of pyelonephritis, urolithiasis.
History of pyelonephritis, these are two different conditions, the same condition.
Infection.
Which is more important, pyelonephritis or urolithiasis?
Pyelonephritis.
Urolithiasis. Why is urolithiasis more important than pyelonephritis?
So because intervention will become difficult. Endourological intervention.
What are you doing when you do a TUU? What are you doing when you do a transureteral ureterostomy to the upper urinary tract? And this will explain to you as to why stone disease is a contraindication to that operation.
Renal diseases will be.
Are two kidneys better or is one kidney better?
You are compromising drainage of both kidneys by making it into one channel.
So,
Stone disease is invariably bilateral. Alright? And if it comes in blocks, both kidneys are in deep trouble. Isn't it? Even a small stone can come and block the recipient ureter. Alright? There are these terms used for the ureter. One is the recipient ureter, the other is the donor ureter. So that ureter gets blocked. Both sides gone. I knew it. What's the other contraindication?
elevated creatinine levels.
What is that got to do with? This is not doing anything to GFR. I was doing drainage. Connected to what is this? Think of conditions where the upper tract could be compromised as a consequence of connecting two ureters together. What is that disease which affects both kidneys and both ureters?
Retroperitoneal fibrosis.
Retroperitoneal. You want to lift the ureter just. Leave alone, bring it from one side to the other.
History of radiations.
Radiation. You won't be able to lift that ureter. Both ureters get affected.
Sorry.
Let us assume that both ureters are not radiated. Both ureters are not retroperitoneal fibrosis. How about TCC? Yeah?
Aneurotelial malignancy.
If there is a history, if there is a problem, it is one operation you can't.
Yes.
Why do you think we didn't do this operation for that fat fellow, Sivakumar? Huh? Because you got TCC. What's the other contraindication?
So TCC. TCC is still.
Sorry? Tuberculosis. Right.
Radiation, tuberculosis.
Tuberculosis. Right. Conditions like radiation and RPF usually are very difficult for it. The standard conditions which are usually where there are contraindications are these, right? Okay. Get it?
Yeah, what do you want to do?
You want to do further imaging or we will take the patient for surgery directly?
So we'll go for CT IVUs.
You want to go one more CT scan, one more radiation for this patient.
After that, MRU.
Sir, I would plan for surgery, sir. I would plan for reconstructive surgery.
We
Directly.
just had a long discussion, man. What will you do next?
Under local versus sedation versus something.
Sir, I would like to go for cystoscopy and vaginoscopy, preferably under anesthesia.
It's called examination and anesthesia.
Yes.
Vignesh, do we have the findings?
No, sir.
What else will you plan? When you're doing this, you said vaginoscopy, okay, examination under anesthesia, cystoscopy, a very, very careful cystoscopy.
Yes, sir.
What else will you plan at that time?
So we can plan for RGP at the same time, sir.
Not can.
Yes, sir. We will do RGP also.
So you want to do examination, reconstruction, everything in the same setting, or you want to do it in two separate settings?
I would like to prefer to do in a separate setting, sir, because patient will also have to be counseled before I go for a major reconstructive procedure.
Okay, what all you will see during examination and anesthesia? Start from urethra.
So the mucosa, sir, we'll see the mucosa. If it is an old lady, there will be senile changes. The urethral meatus has to be seen. And in cystoscopy, we have to assess what is the distance of the fistula from the meatus, and also the fibrotic changes around the fistula's opening for proper classification.
Okay, you can see this fistula at cystoscopy, ureterovaginal fistula. Then what you say? I'll see a cystoscopy fibrotic. Don't confuse VVF with UVF.
Sir.
Think carefully what you're saying.
Sir. To rule out any concomitant VVF.
All right, right. I want to rule out any other concomitant pathology like an additional VVF.
Yes.
Right.
And also
Then what else will you see in the bladder?
the condition of the bladder, the
What
bladder
do you mean by
capacity.
condition?
The bladder capacity.
Say that there are specific terms.
Yes.
I will see the capacity of the bladder under anesthesia.
Yes.
Yeah. You want to confirm whether it's more distensible. Is a normal bladder more distensible under anesthesia or under local?
Under anesthesia.
Why? Think about it as to why the bladder is more distensible under anesthesia vis-a-vis just when I'm sitting around.
So the
My
contraction.
bladder capacities are good. My bladder capacities are good, but I'm more distensible under anesthesia.
So the parasympathetic system
What?
will be.
How will anesthesia affect the parasympathetic system? Unless they give these fancy muscle relaxers, isn't it? They don't need it. Think about it as to why under anesthesia the bladder capacity, now bladder is more. And therefore we use this for certain treatment modalities. Okay, so you see bladder capacity.
Yes, sir. So I would like to go for reconstruction.
Next class we'll ask you the same question. Huh? Don't think we'll forget.
Yes.
Everybody, we'll ask the same question again. Somebody has to find out the answer.
You will have to read very basic chapters on how the bladder behaves.
Yes, sir.
What are the afferents? What are the reflexes? What all happens there?
Yes, sir.
Okay. Okay, do we have the cystoscopy findings?
No,
Very good.
Somebody's done that. Very good. Right, man, Soumya. They listen to you. For the first time, I'm seeing Soumya smiling. Soumya is very stern and he's won a point today, boy. IVU plus CT. Wow.
It is the same day.
Oh, is it the IVU following on the CT? Well, it can't be, in a different.
No, sir. No, because it's already contrast. Maybe there's.
Well, you can do it. Take another room and just take an X-ray shot.
So other than cost, Soumya, what is our objection to doing an IVU? To a CT scan?
Sir, with the help of cystoscopic examination and the regular IVU, we are almost certain about the diagnosis. Doing
What
CT,
is the harm done to the patient when you do a CT scan unnecessarily?
sir, further exposure to radiations.
How much?
How many millisieverts?
So first you tell us the units.
I mean, we have discussed this. I think in the previous batch, we discussed as to what is the effect, how much radiation in a KUB, how much radiation in an IVU, how much radiation in a CT scan. Which is the most?
The CT scan is most 20 to 30
Keywords about
What unit? What is the unit for radiation exposure?
millisieverts.
Millisieverts. Okay. And what is the permissible limit annually? Okay. So that's another homework.
Yes, sir.
Please go and read that.
know this because all of you guys are going to be exposed to the CM. Everybody is doing endourology today. Everybody is doing URS, PCNL. So, you need to be aware of the fact how much of radiation you can have. And I'm speaking from personal experience because when I started doing PCNL, I didn't have this fancy equipment, this CM business. I was doing it on overcouch tube. My hands became black because I was exposed to radiation. My thyroid, the dosimetry indicated fellows from BARC rang up and told the hospital, I told CMC, there's somebody like that who is exposed to radiation, so I had to stop doing the procedure. In my enthusiasm to this thing, I was overexposing with the overhead tube, fixed tube. You don't realize it. So it's very dangerous. That's what happened to me.
So as a side effect, all of urology department had only daughters.
So,
Okay, so we will agree that a CT IVU was not necessary in this patient in case anybody is getting confused. An IVU gives very good information. Please do not waste money and expose the patient to radiation in doing unnecessary CT scans. Okay, so now what do you want to do?
Sir, I would counsel the patient regarding the disease.
You wanted a cystoscopy. Do we have the cystoscopy findings?
go straight to the cysto findings.
End of the.
Okay, so Vignesh, have you done a cystoscopy?
No, sir.
Okay, maybe a good idea to present cases after they have been fully managed. Then the discussion can be done better. Yeah, I think where Prabhu's mouse is, there is some pooling of contrast. We don't know what exactly that is, whether that's the bladder starting or there is extravasation. We'll have to see. Okay, my question is to Soumya.
Yes, sir.
You are the surgeon, you've been called on table. The gynecologist has not injured the ureter, but has told you that I can't find the ureter.
Yes, sir.
Please find the ureter for me. What will you do?
Sir, certain maneuvers are there, sir. I would request the anesthetist, if the BP is okay, then one shot of Lasix would help, sir.
That will be training into the bladder, no? How will you identify? The patient is open.
Open. The laparotony is going on.
Yes,
They
sir.
ask you, please find us the ureter. So how are you expected to identify the ureter in open surgery?
Sir, we would look for, sir, any structure with peristalsis, sir, in that area.
Bowel is moving.
Ayo, this is basic general surgery question. I was a little embarrassed that I was even asking it.
Sir, the ureteric peristalsis, sir, and at the level of the pelvic brim.
Okay,
like
okay. Praveen, can you help him out if you're still there? Praveen?
I am waiting to see if anybody tells the first thing.
I want to inject ICG, sir. If
Okay,
it is
stop.
But the question is very clear. Laparotomy has been done. The gynecologist cannot find the ureter. She comes and tells you, or he comes and tells you, please find it.
So what was the procedure?
What's the first thing that you will look for?
So what
They're doing a salpingo
Gynec will be always pelvic procedure, no? They don't do a upper abdomen.
Very important to know whether there are two kidneys by. Huh? Everybody does their own ultrasound. Gynecologists do only pelvic. If you look at all the reports, pelvic, only pelvis, uterus, ovaries. Nobody looks beyond that. I don't understand this. Why do they not look at the kidneys? So first thing to find out, is there a kidney on that side? Are both kidneys on the same on one side? Huh? You will be digging around there. I have seen this happen. They're digging. That can be tiger country. What is the structure that you're digging and you dig into?
iliac vessel.
Yeah, iliac vessels, vein and artery are the most important structure. You're digging there. You won't find it. So the first thing to do is go back and see, ask the gynecologist, are there two kidneys here? Then you go and look. Then you see where exactly is anatomical.
Yeah, and then where to look, you have to know, man, where to look for this ureter. Where will you find it?
So pelvic brim, sir, at the crossing of the iliac vessels.
And where does it usually go? When you look, you will see only the iliac vessel. So where has you move the peritoneum away, you can see only the iliac vessel crossing.
The strong fellow is retracted.
So where does the ureter go off?
This was told in general area.
Yes, sir.
It goes with the peritoneum. It goes with it.
Yes, sir.
Because pulling.
Laterally it will be.
Because whichever side it is, you're pulling immediately. No, not laterally. The ureter goes with it. So it is, blood is going below water, isn't it? So you take that ureter and go, because you're retracting. In your urgency, in your enthusiasm to retract, you're retracting the peritoneum leaf, which takes the ureter with it. So that's where you may find it's missing. You're looking, where is it? Not there.
How many peristaltic waves you get per minute in ureter? Because the first answer is at peristalsis.
Sir.
Out of syllabus.
Per minute.
Does it depend on the state of diuresis?
Yes, sir.
Yeah. Is that? If the patient is well hydrated, I will see sometimes full column. I won't see peristalsis. It will be a full column because it's pouring like that. But if the patient is normal state of hydration and good, I will see peristalsis about 3 or 4 a minute, 5 or 6, depending on state. That's all. And if you touch it, it moves the same way. You will tell it can peristals even without any urine inside, because that is the inherent property of the ureter. Yes. And having to observe this in a patient where we do cystoscopy, there is no kidney on that side. Everybody just look at this. Next time you do a cystoscopy on a patient whose ureter is retained, the orifice is retained, but there is no kidney on that side. Observe that ureter, you will find that there may be no efflux, but that ureter will move. That ureter will move. We're making this observation and we're seeing it now. Bobby and myself have made this and we're going to say what is the cause. It's obviously not only urine that is demonstrating this. You see it in this fellow also. All these guys, ureter reimplanted, left side, right side, 2 ureters, 3 ureters. Okay, so you know where to put it. And then
We haven't discussed repair. Please go and read it. Okay.
Yes.
Time up.
Yes, sir.
Thanks, Manish.
Thank you. Hi, Karthik. Bye.
Bye, Karthik.
Thank you, sir.